My understanding is that this season of the Selma Medical Humanities Seminar is devoted to counter narratives of reproduction. So I wanted to begin today by telling you a story to keep with the theme. So sit back, relax, and imagine the following scenario. An alarm clock is beeping and John's eyes creak open, landing on a book he was reading the night before called A Man's Guide to Producing Healthy Sperm. He and his wife have been trying to have a baby, and they're doing all they can to improve their chances. He hops in the shower, keeping the water lukewarm so he doesn't cook his sperm, brushes his teeth with a natural toothpaste to avoid excess exposure to chemicals, throws on a shirt and pants he washed with a new detergent stripped of all dyes and scents, and then he heads off to work. On the way, John passes a billboard warning about the effects of aging sperm. Illustrated with an hourglass, the sign's bold-faced type cautions men about their ticking biological clock. And John experiences a twinge of anxiety because he waited until his late 30s to have children. At lunch, he eats a superfood sandwich with avocado, sprouts, and organic cheese, flipping through a men's health magazine with articles about how sperm takes 2.5 months to grow in the male body, and how a man's age and nearly everything he does during that time can damage these cells. Eating unhealthy food, smoking cigarettes, taking drugs, legal or otherwise, and being exposed to other chemicals at work, home, and in the air and he breathes and water he drinks. Back at his desk, a friend stops in to see about a drink after work. John joins the happy hour crew, but opts for juice, thinking about all the times he has seen the standard issue government label on beer bottles, warning that excessive alcohol consumption can damage sperm. John does not want to take any chances. So, as you may have begun to suspect, John is not real. He's a fictional character, and the world that I have described does not exist. Right? Men going about their daily lives are not subject to endless advice about their sperm. They don't encounter books and billboards and warning labels about their reproductive health, nor are they encouraged to visit a doctor on a regular basis to have their reproductive organs examined. And even when they do contemplate becoming a father, men don't experience anxiety about every last morsel they eat or product they use. But they could. In recent years, medical researchers have been amassing evidence that the health of men's bodies, including factors such as their age, behaviors, exposures to toxins, can all damage sperm in such a way that it can actually pose risks to their children's health. Doctors have begun arguing that men have a biological clock, and it was just a few years ago that geneticists demonstrated that with every passing year, men have a greater risk of passing on harmful mutations in their sperm that can be associated with diseases like autism and schizophrenia. And that study actually made the front page of the New York Times. Epidemiologists warn that men who smoke heavily before conception cause changes in their sperm that raises their children's risk of cancer. And the Mayo Clinic packages all of this advice into a patient-friendly page on healthy sperm. And then for their part, of course, we have these men's health magazines who sort of draw on various tropes of masculinity to communicate some of these new findings about, strong, fast, more fertile sperm. So collectively referred to as paternal effects. You may be familiar with maternal effects. Paternal effects, the news here really is that it's not just women's behaviors and women's bodies that can affect reproductive outcomes, which includes everything from miscarriage to birth defects and even illnesses in childhood and beyond. And I will say, right at the outset that a lot of this is fairly new science. And so the kind of amount and type of risk is still very much under study, but it's starting to appear as if men's own health prior to conception does have effects on reproductive outcomes. So my research question was, essentially what took so long, right? After more than a century of asking every possible question about women's reproductive health and women's bodies and women's behaviors, why are we now only beginning to learn some of this very basic information about men's health and how it matters for reproductive outcomes? So my efforts to answer this question took me back to the 19th century as the medical profession began to specialize, and the sort of research is chronicled in this book titled GUYnecology, GUY, The Missing Science of Men's Reproductive Health. And so I look at that history of this lack of attention to men's reproductive health compared to women. And then looking at some of the science that is currently being done. And then finally, I did interviews with men and women from the general public about how they think about men's role in reproductive health. So I'm going to sort of pull little bits of this book, of the research that I did for the book, and talk with you about them today, as well as some of the sort of complexities that emerge from thinking about how is it that we can pay more attention to men's reproductive health. And throughout the talk, you'll sort of hear the different ways that it's, I'm saying men and women and male and female, but even this way of talking about human bodies is sort of rooted in this long-standing understanding of human bodies as, coming in two flavors, either male or female. So this idea of the gender binary and the way that it underpins so much of the knowledge that has been made about reproductive health. And so that's one of the things that I'll come back to at the conclusion of the talk, is how to move forward with thinking about reproductive health and moving, kind of beyond this way of thinking that is rooted in the gender binary. All right, so before I do, and perhaps this is not necessarily an introduction to social scientific approaches to reproduction that needs to be made for this seminar, if you all are hearing from social scientists who study various aspects of reproduction, but I sort of like to put up this slide of the different ways that we can think about reproduction as a case. So you can sort of use reproduction or think with reproduction to understand everything from sort of the making of scientific knowledge, translations of knowledge from bench to bedside, so how it manifests in clinical care, how different medical markets can form around different reproductive technologies or reproductive processes, how all of this is shaped by cultural norms, beliefs about sexed bodies, people's individual experiences, how they define family, and then of course how all of this is shaped by law and policy. You can imagine sort of the different kinds of areas of scientific research that get funded or don't by nation states, public health campaigns that are run or are not run, states banning abortion, making contraception available, right? To take a couple of very current issues in the United States. So this is, sort of set up where it looks hierarchical with scientific knowledge at the top and individuals at the bottom. But if I were better at PowerPoint, I would sort of put this on its side and imagine arrows going from every circle to every other circle, right? And so that's how reproduction can become this very sort of powerful way of thinking about social processes. So in the book, GUYnecology, I use this case of men's reproductive health to examine the relationship between gendered beliefs about bodies and the making of medical knowledge or the production of medical knowledge. And I start with a puzzle. So as women's health activists have been arguing since the 1970s, men's bodies have generally been understood as the standard body for biomedical research. So for most of the 20th century, most medical research was conducted on samples of middle-aged white men on the assumptions that the results would just generalize to everybody else. So our general knowledge about health and medicine was really often knowledge about men's bodies. And it's not until the 1990s that you get women's health advocates successfully pressuring federal agencies in the US, like the National Institutes of Health, to require that women be systematically included in medical research and clinical trials. But this is the puzzle. So if men's bodies have been so central to the making of medical knowledge, right? If they've served as the standard body, then why has so little been known about how their bodies matter for reproductive outcomes? Okay. And by reproductive outcomes, I want to just pull out this last phrase here and be very specific by what I mean. So I mean, how does a man's own age, the status, his own health, his behaviors, and his exposures, how can these things damage sperm in such a way that it can affect the health of resulting children? And this goes beyond questions about sperm count or motility, how many sperm are there? Do they move? Sperm morphology. These are the typical ways of sort of measuring what's called sperm quality. And this goes beyond that. This is really about how sort of men's own health and behaviors and exposures can affect the genetic material inside sperm in a way that matters, or that can matter for their children's health. There are many other ways that men can affect reproductive outcomes, right? If they carry heritable genetic mutations that can cause disease, if they smoke around their partners, if they are domestic abusers, right? So there's a lot of ways that men can matter for reproductive outcomes. I'm really kind of focused here on men's own bodies. And so that sort of limits the scope of the project in important ways. All right, so alongside that longstanding claim about the male body being standard is an equally longstanding claim made by social scientists that the female body has been conceptualized and studied primarily as a reproductive body, with many, many, many biomedical research agendas focused on women's fertility and how women's age and health and behaviors and exposures can affect reproductive outcomes. And so this is where you start to see, you know, the gender binary and the ways that thinking about human bodies is coming in sort of either these sort of two sex categories that are seen as opposite, that are understood as dichotomous, that we are now, you know, really starting to understand gender and sex bodies in very different ways with the advent of sort of people's understanding of trans and gender non-binary and gender non-conforming. So as we start to understand sex and gender in much more complicated ways, part of what I'm doing in this project is showing how the long-standing effects of the gender binary shaping medical knowledge have shaped what it is that we actually know about human bodies. And now that we're starting to put those categories into question, it's raising a whole new set of questions. All right. So, and as I say, like going forward, I'm going to say male and men and female and women, but please, before those categories, you know, if you would insert the preamble, bodies that have historically been defined as male or bodies that have historically been categorized as men's bodies. I'm not going to say it every time, but I'm sort of adding that historical and sociological point to the arguments I'm making about how men's and women's bodies have been understood. All right, so in writing the book, I sort of, you know, it took a while to sort of figure this out, but I came to realize that, you know, these two claims in the gender and medicine literature, which really are, you know, you could almost open any book on gender and medicine and find either or both of these claims, but they've actually evolved somewhat separately. And it's, you know, once you put them up side by side, that I think, you know, sort of tensions begin to emerge. And it's this sort of understanding of the male as standard and the female as reproductive that when you put them next to each other, this is how I argue it's possible to see gaps in medical knowledge forming. So today I'm going to be talking about this gap in knowledge that emerged from not studying reproduction in men, right? And so this sort of gap in knowledge about men's reproductive health. I'll just give you one other example as sort of another comparative way that I think the standard male and the reproductive female come together to produce a gap. And that's in biomedical research on women's cardiovascular disease. So historically, heart attacks were associated with stress and masculinity, and most research was done on men's bodies, which, you know, means that it was not until fairly recently that clinicians started to realize that heart attacks and heart disease sort of manifest and feel differently and look different in women's bodies. And I think that's another example of women primarily being understood as reproductive and not standard, that led to a gap in our knowledge about cardiovascular disease in women. So just, you know, sort of another example here of this social process that I'm interested in, which is sort of how our beliefs about sex and gender bodies are shaping what knowledge we produce. All right, so for, you know, to kind of put together a theoretical framework to study this sort of history and of knowledge making about men's reproduction, I'm essentially pulling together two approaches here. So one of them is recent work in the history and sociology of science about the making of non-knowledge. So there's been a lot of research about how knowledge gets produced, what knowledge is produced, what is it we know, how do we know it? But there's a sort of a new thread in the history and sociology of science about non-knowledge. What is it we don't know, and why don't we know it, and why do we not ask certain questions? And so I'm sort of pulling on some of that literature, and then also pulling together sort of a cultural sociology approach to thinking about production, not only the production or non-production of knowledge, but also its circulation. So once knowledge is starting to be produced about men's reproductive health, is it circulating to a broader public? And then reception. So how is it that people understand or respond to hearing some of this new information about men's reproductive health? So that's where we get sort of production, circulation, and reception. And then I gathered 3 forms of data. So in terms of the production of knowledge, I pulled together a sample, and I did this work with 6 or 7 different research assistants. I'll list them at the end, who really were fantastic in helping with this project. So one of the things that we looked at was all of the Journal of the American Medical Association articles on sperm published from its inception in 1883 to 2014, a similar sample of New York Times articles on sperm for the past 50 years, various other sorts of literature reviews and oral history interviews, medical specialization to kind of understand who is producing new knowledge about men's reproductive health and how are they producing it and where are they publishing it. And then now that this knowledge is starting to be produced, is it circulating and who's sort of trumpeting it? And then the final part was to look at the reception of this knowledge. I did interviews with people from the general community. Okay. All right, so let's take a step back here. And the first question that I really wanted to answer in this book was about how we got to this point, right? How do we get to a male standard body and a female reproductive body? And of course, this distinction had been around for a while. So I started hanging out with the medical historians here at Yale to try to figure out how do you even begin to answer a question like this. And I ended up focusing on a little known, but I argue crucial moment in the 1890s. Political scientists would call this a critical juncture, where there was an attempt to launch a specialty for men's reproductive health called andrology. So it's in those last few decades of the 19th century that the still somewhat new medical profession became engulfed in a wave of professional specialization. And it began to take on the basic shape that it continues to hold to this day. So physicians pointed to rapidly proliferating quantity of medical knowledge and said it's impossible for anybody to keep up with all of this new information. We're at the end of the 19th century here, right? Not today. And instead, so to specialize, they sort of carved up the body into turf for different specialties. So obstetrics and GYN were 2 of the earliest specialties to emerge. And they quickly grew with specialized clinics and specialized journals and conferences. They later formally merged in the 1920s. So it's from the very beginning of medical specialization that you get this sort of powerful feedback loop that locates womanhood in the reproductive tract and reproduction within women, right? And that feedback loop kind of spools all the way through the 20th century. Nellie Uchhorn has done work on the discovery of estrogen and testosterone. You could think about the development of a female contraceptive pill and not a male pill. So there's sort of reverberating effects of women and reproduction being so tightly coupled from those very early days. So it's against that backdrop of medical specialization and not 1, but 2 sort of vibrant specialties focused on women's reproductive organs that Edward Lawrence Keyes, who was a professor of genitourinary surgery at Bellevue in New York City, organizes a small but fairly elite group of physicians to create the American Association for Andrology. And they conceptualized andrology as a parallel to GYN. So here again, you hear that gender binary. And their efforts were the subject of this article in the Journal of the American Medical Association in 1891. And some of the small print says that they hoped that this new specialty would place the diseases of men on as high a plane as GYN and other more established specialties. But unfortunately for them, men's reproductive health at the time was mostly consisted of treating the epidemic venereal disease. Today we would call these sexually transmitted infections, but the epidemic VD of syphilis and gonorrhea in particular. And these were so highly stigmatized that the stigma extended even to these physicians who were trying to treat the men. So those first andrologists were actually ridiculed in medical journals and at medical conferences for the ridiculous idea that they would specialize in men's reproductive organs. They were accused not only of over specialization, but also taking on these unsavory topics like VD that were associated with immorality, sex outside of marriage, and also quackery. So the people who were specializing in VD were typically understood to be quacks. So these folks quickly, Edward Keyes and his friends quickly renamed their association, not andrology, sort of a general term for men's reproductive health, but the American Association for Genitourinary Surgery. And about 10 years after this 1891 editorial, there's a group that sort of really actively starts to try to drop the genito, and they become urologists, right? So today we have urology, which is a large specialty. There's some urologists who focus on men's reproductive health or male fertility, but generally urology is not understood to be sort of a specialty focused on men's reproductive health in the way that OBGYN is today for women. So I argue that that's essentially, that period was essentially a market failure, right? This group fails to launch a medical specialty oriented to fully half the population. And it's brought on by this noxious mix of masculinity and morality at the end of the 19th century, and the effects reverberate to this day. So without a broad umbrella of andrology to gather under, there's no unified biomedical infrastructure, right? There's no annual meetings, there's no singular journal, there's no way for the various scientists and clinicians interested in different aspects of men's reproductive bodies to come together and collaborate and create new knowledge. So that is until 1969, when a German physician named Karl Scheuren started a journal called Andrologie, in which he introduces, this is German for andrology, as a new medical specialty. A year later, a Spaniard and an Argentinian founded the International Society for Andrology. The American branch had its first meeting in 1975. Already you can see that they incorporated sperm into their logo. It was right here. And so the andrologists of the 1970s had no idea that they were not the first ones to think of a specialty and to call it andrology, right? And it's not until the late 1980s they actually found that JAMA article from 1891, and they argued at the time it could be reprinted in full, given its ongoing relevance. All right, so I will say that most people, at least in the United States, have never heard of andrology, right? So this is just a quick engram to show you from 1800 to 2008, obstetrics, gynecology, here's urology coming around 1905, 1910. Andrology is barely clearing the x-axis here, right? And so, it's a small specialty today in the US. We generally find them in sperm banks and fertility clinics. In different countries, andrologists are a little bit more prominent. So there's an interesting sort of national variation in medical specialization here. But at least focusing in on the US, sort of poses this comparative historical question of why does andrology fail outright in the 1890s and then succeed at least a little bit in the 1970s? And here I think the answer is that the various social movements of the 60s and 70s for women's rights and patients' rights, men's rights, really enable new ways of thinking about gender and bodies and medical knowledge, such that a specialty focused on men's reproduction at least becomes thinkable, right? If not, wildly huge and successful. All right. So it's also in the 1970s, we're going to shift here from the production of knowledge to its circulation. So it's also in the 1970s that biomedical researchers began to pay more attention to men's reproductive health and began asking some of these questions about paternal age and behaviors and exposures. And now there is sort of a small body of literature on paternal effects, but still very little efforts being made to systematically circulate that knowledge to the broader public. So we looked through thousands of pages of materials from federal health agencies in the US and professional medical associations in the US, and there is either minimal or zero discussion of paternal effects. If they do talk about it, it's almost always limited to the effects on sperm, so how age or health or exposures affect sperm count or motility or morphology, but almost never do these materials go beyond that to say there's might be concerns about the risk to children's health. The one exception is this one page on the entire CDC website, Centers for Disease Control and Prevention, that summarizes paternal effects under this title of preconception health for men. And that is not a term that anybody would search ever, because it's not sort of a way that people are generally talking about men and preconception health. And it's actually part of a much larger CDC public health campaign on preconception health for women, which Miranda Waggoner has written about in the book, The Zero Trimester. And what they do in this page is they actually cut and paste the page on preconception health for women and retitle it Preconception Health for Men and change the pronouns, right? So it says, make a plan, prevent STDs, but there's actually nothing in here. This is the one place where you might expect to see something about paternal effects, and there's nothing in here at all about the effects of men's health and exposures on sperm, raising concerns for their children's health. All right, so I can keep going about this, but I'm gonna keep moving. All right, so the other place we looked for sort of the circulation of this information, not only on all these, federal health agencies or medical professional organizations, we also looked in the New York Times, and we did a 50-year sample of every article that mentioned the word sperm or synonyms, and went and read through. And so what you see here is that from starting in 1968 to 2018, there are on average about 3 articles per year that do discuss paternal effects. But again, here you see the darker line is the effect, the mention of these effects on sperm cells versus saying that there might be risks to children. And that's a much smaller number. About a third of these articles actually mention something about children. The important thing here, though, is that the number is not 0. So it is possible for this information to be taken up, reported by a journalist, and shared with a broader public. It's not 0, but it's also, as we start to see in the early 2000s, a huge increase in the scientific attention, and the number of publications about paternal effects is just growing exponentially here. We don't see a similar exponential growth in news coverage. So it's being discussed, but it's not sort of a focus of attention. It's not getting additional attention as more information is being learned. Okay, so the question you might be asking yourself is, why does all of this history matter, right? Why do we have to go all the way back to the 19th century to make this argument? And I would say that it's really about the lack of a cohesive, singular medical specialty devoted solely to men's reproductive health. I think that's why there's been so little medical research and even less public health attention to men and their sperm. And so it's that void, right, that gap in both biomedical research and public health messaging that raises questions that I tackle in this last part of the book. So here I drew on interviews that I did with 40 men and 15 women, people who identified as men and people who identified as women, drawn from the general community in a small northeastern American city. And I spend a chapter on each of these questions. Right? So in a world in which we pay so little attention to men's reproductive health, how is it that people define a man's role in reproduction? And how do they react to learning some of this new information about how a man's age, health, behaviors, and exposures prior to conception might affect their children's health? So just a brief word about methods due to time, but I'm happy to answer questions. You can see, I put up these flyers around the city. Some of them were online, some of them were sort of physically put in cafes and libraries and such. It did not say anything at all about reproduction or sperm. So I was seeking volunteers to talk about life experiences. About half the respondents all of the respondents were of reproductive age, so sort of using that same number for women 18 to 49. Half were parents, half were not. Half had sort of a higher socioeconomic status, half lower socioeconomic status, half were white, half were people of color. This was actually one of the first interview studies to ask men generally for their views of reproduction. Because social scientists too have primarily focused on women and reproduction, just like our clinician friends. So, and sort of trying to figure out the lay of the land and to map the kind of cognitive landscape of how people think about men's role in reproduction, I was trying to recruit people from as many different backgrounds as possible. And so that's why I was really looking for sort of people from a variety of different in terms of demographic categories of how we think about this in sociology, people from a variety of these sort of intersecting categories. All right, so because I didn't say anything in the recruitment materials about sperm or reproduction, I would spend the first 20 minutes of the interview asking questions about their life experiences, asking about their childhood, schooling, workplace experiences, and then I would ask a few questions about did they have a family, did they want to have a family, and that would allow me to sort of transition to asking some of these questions about, if someone, this was the first sort of question I would transition to. And I said, if somebody asked you to describe a man's role in reproduction, sorry, you'll hear a little bit of the wind coming through my rickety old windows here. So if someone asked you to describe a man's role in reproduction, how would you describe it? So you can take a minute, think about how you would answer that question. Here I used the word reproduction because I really wanted people to focus on men's bodily contributions to their offspring. So I thought if I asked about fatherhood or having children, that might lead them to talk about what you do with children when they're born. So when I ask men this question, they respond with long pauses. This is one of the more extreme examples. So Nathan is a 31-year-old white high school graduate with no children. He says, a man's role in reproduction. Wow, never thought about that before. I don't think it'd be too different from a woman's role. A man's, what would my role be? Can you rephrase the question? So here I'm taking the pauses and the ums as data. For some men like Nathan, the pauses demonstrate a lack of a readily accessible cultural script about men's role in reproduction. Men have no idea what to say. They've not ever thought much about it, and they've certainly never been asked to say it out loud. And I think this reflects our more general inattention to how men matter for reproduction. But after people stumble around a bit, they generally end up defining a man's role in reproduction in three parts: having sex, providing sperm, and then just providing more generally, economically, emotionally for the family. So these are examples of this. So Angelo says a man's role in reproduction, apart from the sexual act. Kenneth says, well, the man provides the sperm, that fertilizes the egg, so that's his role. And then Gary gives us sort of this well-known kind of ideal type picture of what a father is. He's the provider, the caretaker, the supporter. He says this is what every man needs to do in order to secure their family. And I put up this last quote not because it's news to anybody who's ever studied men or fatherhood or masculinity, but because of just how easily this answer sort of rolls off the tongue. There's no ums, there's no pauses, and I heard a version of this from almost everybody I interviewed. So I think, it sort of just is a nice contrast to how difficult it is to define what a man's role in reproduction. All right, we're going to take a little bit of a deeper dive into bullet point 2 here. And so as another way of getting men to talk about their bodily involvement in reproduction, I then asked, okay, well, how would you describe the relationship between an egg and a sperm? And so I'd had, very few hypotheses about how men were going to talk about their role in reproduction. But here I really did expect, on the basis of sort of Emily Martin's classic article on the active sperm and passive egg and the ways that our understandings of masculinity and femininity shape how we understand these cells. that I really did expect this sort of traditional tale of, active sperm racing to penetrate the passive egg. It's the story that is still being told in medical textbooks and popular documentaries to this day. It's the one that a lot of us probably heard in school. And indeed, about 90% of the people I interviewed did tell a version of this old story. And this is an example from Bruce, who's a 38-year-old African-American father working as a hotel janitor, and he's raising a teenage son by himself. And he says, well, I describe sperm as multiple busybodies in a race, and it's more or less like, let's see who can get there first. Everybody's just pushing each other out of the way just to get to the egg, and that's the golden prize, so to speak. So it's like whoever's the fastest, the most intelligent one. I know it's not necessarily like that, but it's like the one that wins the race, right? But the interesting thing was that this was not the only story that I heard men tell. Whereas you've got the active sperm, passive egg story, and it's, that's a narrative in which men really are put in the sort of active role of establishing a pregnancy, where men cause pregnancy, which if you take a step back, that starts to become a very sort of interesting way to think about it. But it's deeply woven into sort of how it is we talk about reproduction, right? You can think about it, he got her pregnant or he knocked her up. But as I mentioned, it's not the only way that people talked about eggs and sperm. I also heard a second story in which eggs and sperm were it's a more egalitarian tale where they're more equals, where they're equally active, they're equally necessary, they're equally important. So here are two examples. Patrick says, I describe the relationship between the egg and the sperm like, let's see, how do I say it? Like two necessary components that need to come together to create something much larger. And Luke says, well, it's like two-part epoxy where there's two strips and they're each a different color. You mix the strips together and then you've actually got epoxy that will harden and form a seal on whatever you want. So at this point I laugh and say, I've never heard of this. He says, well, sperm's not doing anything on its own. The egg's not doing anything on its own. Those two things have to combine for a child to exist. So in contrast to the active sperm, passive egg story, that second story, there's no race, there's no penetration, there's no competition, right? There's just this combination, this coming together. And I think it's important to note that these two narratives, these two sperm stories, are not mutually exclusive. So like I said, almost everybody told the first one, and then about half the people went on to tell the second story, in which the eggs and sperm sort of appear to be more egalitarian. And I was interested in who told that second story. And so I went back with a research assistant and we recoded all of the interviews that we did and categorized people as more gender egalitarian or less gender egalitarian based on, their other talk in the interview, not related to eggs and sperm. And so this is just a chart to show you that, here's the active sperm, passive egg story being told by almost everybody. Here's the less egalitarian men and the more egalitarian men. And you can see that those who we coded as more egalitarian were about twice as likely to tell that second story. So biological stories, right? And in this case, these biological stories about sperm and eggs are powerful. They're both reflecting and producing our collective understandings of our bodies and ourselves. And this part of the analysis reveals people telling two very different kinds of stories about the exact same cells. And the point here is not that it's eggs or sperm that are more or less egalitarian, but these biological stories that we tell about them that are. All right, so just as important as noticing what people say is what they do not say. And what's missing in men's answers to my questions about reproduction and eggs and sperm is any discussion whatsoever about how the age and health of men's bodies prior to conception might affect the health of their children. So men and women are conceptualizing men as this active agent who establishes pregnancy. They're pointing to sperm as the spark of life, the sort of very old notion of the seed in the soil. But there's not yet this cognitive connection between sperm and the health of male bodies. And that's exactly the connection being suggested by recent medical research. So I want to just take a brief look at how men reacted to learning that. And then I will wrap up. So since there were no patient brochures that I could find about paternal effects, I wrote my own. So I called it Healthy Sperm, and I sort of parroted the kinds of individual focused health advice that would be common in public health materials, right? Here's what you can do to, this damages your sperm. Women are not the only ones with a biological clock. Damaged sperm raises the risk of birth defects and childhood illnesses. And here's what you can do to make healthy sperm. Okay, so I had, after a couple of more questions about reproduction and health, I had men read this brochure and then walk me through their responses. And I sort of, I wasn't quite sure how people were going to react. I thought, they might push back and say, no, it's really women who matter. But in fact, every single person I interviewed said, well, of course, I would do everything I possibly could to give my children the best chance in life. So of course, I would follow this advice, right? And in sociology, this is what we call social desirability bias, where you give the answers you're expected to give. So to get around that, my next question would be like, okay, that's how you would respond. Now I want to have you think about the average man and how would he respond? And then people brought up a whole lot of reasons why men would not pay any attention to their reproductive health whatsoever. So they ranged from things like cultural norms of masculinity, where people argued, men think they have super sperm and they're immortal and nothing can hurt them. They talked about the gap, the very well-documented gap between health intentions and health behaviors, how we all know to do this, but none of us do. And then I think a really important sort of critique that emanated from these interviews with people from, everyday walks of life and all kinds of backgrounds, that people talked a lot about sort of the various structural and environmental threats to health, from healthcare inequalities to poverty to chemicals at work, in the air, in the water, that are not under the control of individuals and the choices that they are making, right? That we are all subject to these broader social and structural forces that have huge effects on an individual body's health that they don't necessarily have any power to change. And I think that's a really important point, and one that I want to sort of conclude on today. All right. So to conclude, I am attempting to reach a variety of different audiences with this research, from social scientists to biomedical researchers, healthcare providers, and public health policymakers. And I would say that, if there was a bumper sticker version of this book, it would be that we need to all pay more attention to men's reproductive health. From a social science perspective, I think studying what is not known and what wasn't thinkable can reveal how cultural beliefs, in this case around gender, but of course gender is always intersecting with other inequalities around race and sexuality and class, that these sort of cultural beliefs and these social processes have a profound effect on knowledge making, and not only what knowledge is made, but what knowledge is not made. So even though I am putting up this sort of bumper sticker sort of version of this, at the same time, I really want to call attention to a number of the complexities that emerge when making the argument that we should pay more attention to men's reproductive health, especially as I transition from sort of talking to my fellow social scientists to talking to biomedical researchers. So some of those complexities, and here I want to put, men's reproductive health, men, into quotation marks. So for biomedical researchers, on the one hand, I think it's very important to not only study people who identify as women or bodies that we have categorized historically as female. If we are only studying women's bodies when it comes to reproductive risk, then we are missing some amount of risk that comes from other bodies that are involved in reproduction, as well as the sort of more structural and environmental contributors to ill health. So I think biomedical researchers who ignore men are missing some unknown amount of reproductive risk. But the complexity here is that at the same time, we don't necessarily want to reify the gender binary. And so studying women's reproductive health next to men's reproductive health really does run a very serious risk of continuing to perpetuate the idea that bodies just come in these two categories, when we know that the range of sort of bodies and bodily characteristics and people's gender identities are far more complicated. In terms of healthcare providers, I think it's really important to, again, not just take reproductive health care and use that as a synonym for women's health care, or to only be running clinics with women patients in mind, or people who have eggs or uteruses or could become pregnant, that we need to think about the reproductive health of all bodies, regardless of sex assigned at birth or gender identity. And I think, one of the questions that I sometimes get is, should there be a whole other specialty for men's reproductive health? And I think the answer to that is no. I think we need to take reproductive health, which is a gender neutral term, and expand that umbrella. It's already expanding from women to trans people and intersex and non-binary people, to go ahead and continue expanding it to include men and all people, really. So that if we think about reproductive healthcare as something that everyone needs and not just women, I think that raises lots of new questions about the kinds of healthcare that get provided, the kinds of recommendations that get made. The complexity here is that at the same time, we also have to be mindful that, at least in the United States, we are in a situation where basic access to historical forms of reproductive health care, like abortion and contraception, are under extraordinary threat. And so I don't want to be naive or dismissive of that very important political context. And so how can we think about the reproductive health and reproductive justice for all people without, sort of ignoring the particular challenges that are faced by people who do have the possibility or have an interest in becoming pregnant, or have an interest in not being pregnant, right? Okay, and then finally, for public health policymakers, I would say that it's the newness of men's reproductive health, right? This idea that we haven't really thought about this category much and haven't produced much information, that I want to sort of draw on that newness to think about how we can do a better job with reproductive health messaging for everyone. So in general, our public health campaigns tend to focus attention at the individual level on individual bodies and individual behaviors. They often stigmatize and moralize and blame. And in some cases, people are even, women and pregnant people have even been incarcerated for some of their behavior during pregnancy. So I don't want to take all of that, really problematic approach and just spread that around to everybody. I think we ought to take the opportunity to pause and think about how we can do a much better job with health messages that don't individualize and don't stigmatize and don't moralize. And part of that is really kind of finally taking these steps, not just to focus on individual health, but to shift our attention to much broader structural and environmental processes that affect the health of everybody, and that would improve everybody's health, regardless of whether or not they're having children. Okay, I will stop there. Thank you so much. Let me just say my thanks here to my research assistants and to the funding agencies and to all of you for joining us this morning. I'm happy to hear questions and comments and look forward to the discussion.